Matt, can you shed some light on some of the contributions that Harvard and your department at Harvard and Wellman has really contributed to this field?
Yeah, there have been some really major contributions in terms of lasers. The most common use of lasers in medicine is laser hair removal. That was developed at Mass General at Wellman by Rox Anderson and Melanie Grossman. We also had laser tattoo removal, Q-switch lasers and picosecond lasers, also developed by Rox. Fractional resurfacing, non-ablative fractional resurfacing, that is, Dieter Manstein and Rox Anderson, cool sculpting, Dieter Manstein and Rox Anderson, pulse dye laser that was developed by Rox prior to his dermatology residency. We talked about the 1450 nanometer diode laser, that we don't use too much anymore. That was developed as well for acne, for non-ablative resurfacing, and for sebaceous hyperplasia. Dr. Kilmer's used that. And even laser lithotripsy, there are devices as well. So just multiple devices that have been used, laser on and non-laser based. And I think you'll see over the next few years, many important contributions continuing to come out of Mass General Wellman.
We have a lot of folks on this panel who've made major contributions. Brian, can you talk a little bit about perfluorodecolin, the PFD patches that are used for tattoo removal?
The PFD patches are, as Joel said, something that you use for tattoo removal. It's a silicone patch which is infused with an inert liquid called perfluorodecolin, or PFD. PFD does a couple different things that will enhance both the efficacy and the safety of laser-assisted tattoo removal, whether you're using nanosecond or picosecond wavelengths. The limiting factor, one of the limiting factors in doing tattoo removal treatments, of course, is the epidermal whitening. And one of the things that PFD will do is it will minimize the epidermal whitening to allow you to do multiple passes with laser simultaneously. That allows treatments to be more efficacious. Rather than doing just a single pass and being done, you can do multiple. PFD also reduces scatter in tissue, so you can get deeper penetration of laser light. So at least in theory, should be able to get better efficacy of ink, which is found more deeply placed. And then the third potential benefit is that the PFD can help act as a heat sink to absorb heat and further help limit epidermal injury. So it can contribute both to safety and efficacy in laser-assisted removal.
So I want to change topics to something that we all do on a regular basis. So all of us on this panel do a lot of fillers, and all of us on this panel do a lot of lasers and other energy-based devices like radio frequency. And I want to talk about the questions that we get about durability. There have been some studies looking at placing filler and doing laser over it and really not affecting the overall durability. And then Bob Weiss did a study where perhaps radio frequency, in particular deeper radio frequency, could. So how do you really think about this when you're educating residents or fellows and just thinking about the combinations that we do? Chris, if you want to start with that.
Well, frequently, traditionally, we would often say we're placing this filler high in the dermis, for instance, or in the mid dermis. And there was a very good study, 6 or 7 years ago, which demonstrated that actually a lot of it went in the subcutaneous space. And so some of the devices that we're using, like the fractionated devices, which can get down 1.5 millimeters or so, you'd imagine would have an impact on the fillers with very superficial placement. The study on radio frequency that I think you were referring to actually demonstrated that there was persistence despite use of RF, and that it didn't necessarily negatively impact it. They thought it was actually additive, the benefit. So generally speaking, I don't think it's going to impact most fillers. Certainly things like Radiesse, things like Sculptra, for instance, which you're going to be placing deeper. Those items like the Bellateros, for instance, where you're putting higher up, I think could be subject to some changes. Other thoughts?
I think if you're going after etched lines, then certainly you may affect the durability of it. But in general, I think we're placing things in the deep dermis, and in fact, as you indicated, more often in the sub-Q, and for sure we're placing many things on the periosteum. John Arlett, who's a Mohs surgeon up in Canada, published an article in Derm Surgery several years ago where he actually had patients who had basal cell carcinomas in the nasolabial fold area, and he got IRB approval to actually, and consent with the patients, when he was removing the basal cell, he got their consent to place filler, HA filler, in what he thought was the dermis around that area, just to see where it was histologically. And it turns out that more often than not, he was much deeper than the dermis. So by and large, the dermal thickness was 1.2 to 1.4 millimeters. And if you look at Hale's colloidal iron or even H&E in his particular projects, you can see the HA in the sub-Q, and it was down at like 2.4 millimeters. So I think that's important to think about. Susie, when you're taking care of patients and you're doing these types of procedures, how do you answer that question in terms of durability? And then do you think it differs with ultrasound?
You know, I haven't looked at ultrasound. For the lasers, I don't think it matters. I've gone over the top. In fact, in some cases with deep rhytids of the upper lip, we actually started this technique where we popped them up a little bit so that we could get laser resurfacing to work better, and it worked really well. Actually, Susan Silva here really came up with that idea, and then we kind of looked at it. One thing we did look at was with botulinum toxin, the neuromodulators, and could any of the devices interfere with that? And the study that we did included monopolar RF, therapy. So we did look at it for botulinum toxin, but I have not looked at it with filler. Pulse dye laser, smooth 1450, 1320, and IPL, and none of those caused any issue with botulinum toxin or any kind of, and we did device followed by toxin and toxin followed by device, one on each side. The one thing that has come up, that came up after that paper was published, was that the fractional devices get a lot more swelling. So again, a little bit different subject, but one of the things to make sure of that if you do devices and you have toxin that's been recently put in place, and the current hours is 26 hours per allergen. If you get swelling, you could make that botulinum toxin migrate. And I've done that in 3 people, but now it's just a hard and fast rule. But I have not looked at ultrasound, but I have done ultrasound over fillers, and no one seems to have, because we do a lot of the newer one, no one seems to have had an issue with that, but I'm ready to be educated.
Matt, your take on durability and energy-based devices when we're talking about fillers?
Yeah, I mean, overall, I agree with everything that's been stated. I think if you're doing fine lines and you're going very superficially and you're using a device that penetrates deeply enough, you're going to run into an issue. But I'm actually amazed at how little this ends up being an issue. You would think it would happen more. I mean, you'd think that some of the heat would get a little bit deeper, but for the most part, it looks like it's pretty good. I think Susie brought up a good issue, which is use of neurotoxins when you are doing lasers that cause swelling. There was a paper recently published that showed that in one practice that they didn't get any events with botulinum toxin migration or diffusion after treatment. I teach my fellows and residents my lecture to avoid that issue altogether and to inject on different days based on what Susie taught me, because it's happened to other people as well. And if you do enough of anything, you're going to see it as an issue.
It's definitely happened a lot.
Yeah.
If that does occur, it's very, very rare. But if you think about the areas where it can occur, first of all, when people are injecting the interior aspect of the orbicularis oculi, it's really adjacent to where the zygomaticus minor is. So if you're doing like a non-ablative laser and you're getting swelling, it's not that far a distance to travel with that swelling to knock out the zygomaticus minor as well as the major. And then secondly, I've seen it, and one of our friends and colleagues shared with me, he did a heavy TCA peel around the mouth, he injected the DAO muscle on the side, up about a centimeter from the jawline, and somehow that diffused medially to the depressor labii inferioris just from that swelling. So I think it is something that we should be cautious about.
Also,
Especially
the
the
bunny
parent-
lines right here, that's another issue. Because if you get swelling there, it'll run down and pick off the levator.
I'm going to have you share some experience with us.
CO2 resurfacing, and this is actually a case of mine. So I came back from a meeting and I saw the patient walking by, and I was actually in my street clothes. I'm like, what's going on with her? Because it looks like pus. She'd had 2 cultures that came back normal flora. And I said, no, culture again, do anaerobic cultures. It turned out it grew Peptostreptococcus. Got her on, she'd actually been put onto, we put her onto Cipro and she did great. But it took a lot of hand holding. So sometimes remember that when you have an infection and you have resurfaced skin, that bacteria can eat in deeper. So Matt, do you have yours?
So this is the patient. So this is a 66-year-old female treated by a plastic surgeon locally that day, liposuction, thread lift, and then perioral CO2 treatment. The patient was otherwise healthy. This is the recovery. This is a photo that the patient shared with me. And this is what, when she comes to see me 2 months later at Mass General, notes these red perioral hypertrophic scars and notes difficulty opening her mouth due to scarring. So you can see that here. She has a contracture scar as well. So what you have here is just, and I'll go back to the prior picture, hypertrophic scarring, erythematous scars, contracture scars as a result of an aggressive laser treatment. So Joel, how would you like to pursue? Should we go to the group and get thoughts about what they would do, or should we just kind of say what we
Back
did?
up to that first picture, because that was pretty impressive. My people don't look like this after resurfacing.
That's why pretty striking.
Yeah.
So Chris, how would you handle this first step along the way?
Well, obviously, apart from appropriate cultures, etc., this patient needs to immediately come in to be seen, to be cleaned, photographed, and you need to reassure the patient that they're going to be fine. Whether you actually believe it or not is another thing, but you tell them they're calm, that they're going to be fine, so they'll just relax. If they're in pain, you treat that, etc. In terms of this is likely to be bacterial, could also be viral, could be candidal. So I would treat with appropriate medications for all of those. But one of the most important things is care. How are you going to clean it? You're probably going to use. You could use your Resurfacing, for instance. I tend to use dilute peroxide or acetic acid vinegar. Keep it moist, do all the usual things, see the patient on a regular basis, things can get bad very quickly, and they can also improve relatively quickly as well. So that would really be my mainstay.
Right. So as far as the cultures, I just want to point out, it's important to actually make sure that your cultures are broad, as Susie indicated, making sure that you take everything into account. One thing that I learned with fillers and somebody who had an abscess is that you really want to make sure that you identify things like atypical mycobacteria is of interest, because that's a different type of culture and that tends to be a more delayed. Yeah. So really identify to them. And then in terms of our panel, from a prophylaxis standpoint, I give everybody Valtrex prophylaxis. The higher bioavailability with Valtrex than Acyclovir makes sense. And now that Valtrex is generic, it's more affordable. I don't give oral antibiotics. And I found in many cases when their oral antibiotics have been given, if a patient has an infection, it's something that's not covered. I don't know what they would have had they not been on the oral antibiotics, but it's something that is not covered. For instance, if you give Keflex and somebody has some gram-negative type of issue, that's typically not covered. So, and then in terms of prep and things like that. I agree with Susie, Laserson, and sending him home with that and having him do some acetic acid, dilute acetic acid with distilled water. Mitch Goldman published something where there was actually a mycobacterium outbreak in the water in San Diego, and he published it in Cosmetic Dermatology, and it wasn't found out until later that this was going on and was a contaminant. So I have people distilled water with acetic acid, that white vinegar. So let's go to the picture of the scarring. Susie, how would you propose treating?
This you want deep fractional ablative, so you can get in there. But before, I'll tell you that if somebody had jumped in and realized that this was going to be a problem and started doing low-level pulse dye laser, when they have that sort of red eczematous look to them, you can actually stop the scarring and slow it down.
What type of settings are you talking about from the low-level pulse dye?
Say that again.
What type of settings are you talking about? Low-level.
I'll do 3 milliseconds or 1.5 milliseconds. It kind of depends on how red, how active, how angry. But lower pulse widths or shorter pulse widths and a little bit lower energy, especially in the very beginning, because it almost can look like eczematous and friable. And in that case, I was just telling about with the infection, I did it on her that day because I was hoping to kill any bacteria that were there with the energy. And we turned her around. I mean, there was definitely hand holding, but there's nothing you can see now. And I think my case could have looked like this if we hadn't gotten it, because it was a very aggressive infection. And some of these infections are super aggressive.
Just to go over the settings again, 1.5 milliseconds or 3 milliseconds, but the low energy, you're talking about like 5.5 joules.
Yeah, exactly. And maybe even a little bit lower depending on how red. So somewhere between 4 and 6. Okay. And then as they get a little bit better, I'll stretch the pulse width out a little bit, because now they don't want to have any purpura. And when you go with the higher energies, you could get a little bit more purpura. And then, because I'm still trying to like stop this thing. And then I'll do 3 to 6 milliseconds, and then 5 to 7 joules per centimeter squared in a 10 millimeter spot. And I'll see them, because I've had a couple people, I had one woman sent to me that would have looked, her entire face almost looked like this. And all I had was pulse dye laser at the time. There was no fractional lasers, and I got her back to almost normal skin. But now what I would do is I would do pulse dye laser. Let's say she came in today and she looks like this. I would do pulse dye laser, but she's a little bit, she's farther out, right? So I would do probably 10 millimeter spot, 3 to 6 milliseconds. I don't want to cause purpura because you don't want to cause any more trauma. So it probably would be 6 milliseconds and probably 6 to 7 joules per centimeter squared. And then right over the top, I would do fractional ablative. And then you can either do erbium or I have a scar effects, which is a deeper, I can go deeper, and these are deep scars. These are 3 millimeters deep. So I want to get low density, 3 to 5% at the most, and maybe even 100 to 150 millijoules.
So I might approach this with pulse dye laser on the same day as a non-ablative fractional, and then do a little laser-assisted drug delivery with some Kenalog.
Oh, yes, and add that in.
So
I would do ablative. I would actually be thinking ablative just to get the drug in there, and to remember, when you ablate that tissue, you're actually removing scar tissue and you're allowing new collagen to be in there. And non-ablative isn't going to be as effective, but I would just go really low density. And then I would do 5FU with, like a little bit of Kenalog in it.
So Brian, what about you?
Yeah, I certainly agree with everything that's been said. And a lot of it is really a clinical call based on not just what the tissue looks like, but what it feels like. And you can tell if it's still soft, you've got a lot more, I think, time to work with. If it's already getting tight, like Sue said, you get real aggressive. And I also use 5FU steroids. I use topical steroids at home as well. Jeff Dover's talked about and published using clobetasol for some of these patients. You got to sort of throw everything at them, but I agree that ablative fractional vascular laser, I actually will use long pulse 1064. We're getting deeper. If I feel like I need to get a deeper vascular effect than I can get with a pulse dye, I'll also use long pulse 1064. And I really feel like that's moved me along on some scars. sort of gotten to the point where they just weren't moving as much.
What
A
settings are you using?
What settings am I using?
Yeah,
For the long pulse 1064?
yeah, because I haven't done that. That sounds interesting. Yeah.
So it depends on the size of the scar. If it's a surgical scar, I'll use a small spot size, like a 3mm spot, fluence of around 150-ish joules per square centimeter, pulse duration 20 to 40 milliseconds, 20 to 30 milliseconds somewhere. If it's a larger scar and you need a larger spot size, something like this, I'd use settings that are actually closer to hair removal settings.
You know,
Can I just add? I had a patient who I did full face erbium YAG laser, was healing just fine, 10 days, 2 weeks, and she started to develop these angulated red areas that we've all seen, and she's gonna get scarring. And I treated her in the appropriate way, but the underlying thing is that she had malabsorption syndrome with very low albumin. So sometimes when this sort of thing happens, when there's no very good reason, where there's no obvious bacterial or viral issue, just think about underlying medical problems. The other thing is that this woman is probably going to have delayed onset permanent loss of pigmentation.
Mm-hmm.
And one of the questions here is then, how are you going to handle it long term? What do we actually think that loss of pigmentation can be? Well, first of all, what's it caused by? And secondly, do we think we can ameliorate it?
So, you know, from a standpoint of, I think using an ablative laser on somebody who had an injury caused by an ablative laser is a very difficult conversation. So when I suggested going to a non-ablative fractional with pulse dye laser, you know, I think that makes sense for some patients and allows you to treat more frequently. But if you get an interval where, you know, somebody may allow for the downtime, Susie, what would you be comfortable with? And then secondly, you know, when we think about ablative and non-ablative fractional lasers, the original description of repigmentation from the Misaki regimen, Misaki and Fitzpatrick published, was using non-ablative fractional and bimatoprost, Latisse, and doing a series of treatments. They actually did 4 treatments about 4 weeks apart. Some of those patients had retin-A, so it wasn't totally just bimatoprost and laser, but I don't think the retin-A helped, you know, contribute to the improvement of the pigment. It maybe just did something to the stratum corneum in terms of access with the bimatoprost. But Jill Weibel published an article in JDD just last year, about a year ago right now, that the bimatoprost seems to work better when you're doing an ablative fractional laser. So I just, you know, in answer to your question, I think that now the data supports doing ablative fractional, as Susie indicated, with the bimatoprost.
Yeah, and I do them 1 month apart, and just gingerly, like, sort of increasing the you know, how aggressively I'm treating her as she gets better and better. And obviously the first couple times you want to be careful with her, but I don't think you're going to get anywhere with non-ablative with something like this. As far as the, you know, but I totally get your point that, and I say that, I know it sounds really crazy. You've just had an ablative laser, because of course I get these referred here. And it's nice to be able to be comfortable saying that I think I can remove more scar tissue. And I literally say it that way. If I do the ablative fractional, I'll be able to take some of that scar tissue out and you'll get new tissue in there. And as far as the bimatoprost, I think that the ablative works a little bit better. In the other study is Rhett Hatterstall, that shows that if there's a little bit of coagulum in those columns, you have a reservoir. And so whatever drug you put in there does better, because you allow some of it to sort of get stuck in the columns. But I do think doing the non-ablative, because you do break the barrier by doing the non-ablative. So I think for the pigment, because Chris is exactly right, this woman's going to be mostly depigmented. And as to his question, I'm assuming that the melanocytes probably got wiped out by the laser and the, no? What do you think, Matt?
Just in focal spots. So I fortunately saw this patient again recently, and there are a couple little focal areas where there's a degree of depigmentation, but most of it actually is not some of this is probably just an artifact of the flash. Most of the skin is actually now kind of at the normal color, and I can show kind of what we did, but there are a couple of spots, but there isn't the depigmentation that
Wow.
we normally see, and maybe that's a result of the treatments that were done to make this better, which is possible. And I can go through what we did. It didn't include Latisse.
I'd love to hear what you did.
So what I did, so one thing that's easier about having the conversation about doing ablative again is you can see this contracture scarring here. She is really not opening her mouth much at all. I told her that if we use an ablative fractional laser, and she had full field, this is ablative fractional, so it is a little bit different, but I've had this experience before. People are afraid of getting an ablative laser again. My pitch was, listen, we need to be able to open your mouth more, and we might even be able to have your mouth open more immediately after the procedure. So that was how we kind of got buy-in, and that's why we went with the ablative fractional treatment. And I'm going through kind of what I did. So what I did was I did pulse dye laser, and what we do for scars is we do low fluence because they're smaller vessels. And again, Susie's right. If this happens in the rest of the panels do the same thing. If it happens right away, low fluence, low energy, and you get that started right away. This was more mature, but same principle. We're treating scars here. We're not treating telangiectasias, and there's a big difference between them. We're not trying to ablate all the vessels. We're trying to get an improvement in the vessels, but not go so strong that we get the scar to kick up again. So low fluence, wider spot size, and short pulse duration. And then, so here there was some purpura as well. We kind of went right along that endpoint there.
Mm-hmm.
And then we did ablative this is CO2 ablative fractional resurfacing. And I did exactly what some of the other panelists have discussed. Deep penetration here. So this is on this device, 70 millijoules, which is 1500 micrometers into the skin. Level 3, so very, very low density. And again, for some of the same principles, I did that with the pulse dye laser, which is, again, you're treating scars, so you kind of want to do this gently. And then finally, so that's what she looked like after treatment. Then the next thing is we didn't do the 5FU on this treatment. We just did the IL Kenalog. I do some drops of the IL Kenalog and then kind of rub them in. So that's what we did. So we did ablative CO2 resurfacing, low density but deep, short pulse duration, wide spot size, low fluence pulse dye laser, and then topical drug delivery. And you can see this is after a couple of treatments, how the extent of her ability to move. And this is in due credit to the Navy guys in San Diego who showed that they could do this with the wounded warriors coming back from overseas with range of motion of the shoulder and things like that. I've seen this with dog bites as well. People have been bit around the mouth, and you can see a very nice improvement there. This was a while ago. We've had further treatments, so we've seen more improvement, but you can still see a very nice improvement here. Getting to the point, certainly in the upper lip where makeup is mostly sufficient. And I wanted to point out, there isn't a lot of hypopigmentation there. There's a spot over there, maybe over there, where the scars are really, more severe. And I don't know if it would have hypopigmented. It absolutely stands to reason that it would have. I wonder if maybe because there is the ablative fractional resurfacing, maybe the melanocytes had a chance to kind of migrate in and restore her normal pigmentation. Because it is a good point. You would have expected this to all be hypopigmented.
So we've covered some really tough scenarios and tough topics in dermatologic and laser surgery. And I appreciate the panel being with us. I want to wrap things up with really a conversation very quickly about some of the things that have been seen in terms of what has led to litigation when it comes to lasers. Matt, you've written about this, looking at all the different types of laser cases, and laser hair removal and IPL are top of the list. And Chris, you've actually written very recently with Roy Geronimus and then Jordan Wang, who has been a superstar in really designing many studies looking at who's doing what in what type of facilities, and what the term supervision actually means to people. So just briefly, Matt, talk about what you found in when you're compiling this data about litigation, and then Chris, talk about the project that you did with Jordan Wang.
So a couple of things. We've done 2 large-scale studies looking at litigation with laser surgery. Did that with Ray Jalian, and more recently with Dr. Sami Khalifian, which is in publication now, which was an update. Quick story, laser hair removal is the most common reason for laser litigation. Number 2 is rejuvenation procedures, mostly IPL. And I think to make sense because they have to do with pigmentation and people having a false sense of security with those devices. They tend to be malpractice action and informed consent actions. The setting, we did a lot of work looking at the setting of where these happen. And both in the early JAMA Dermatology articles back in 2014, and most recently presented at ASLMS and submitted as well. And the overwhelming proportion of cases are cases in a setting where there is not supervision. So in other words, a medi-spa. So instances where you have non-physicians performing treatments without supervision in medi-spas. And in terms of the regulation state to state, Catherine DeGiorgio and I did a nice review of the state laws in the 50 states. It's on the ASLMS website, it's on the ASDS website, and it's been published, that shows the degree to which there are differences in terms of what supervision means in one state versus supervision in another.
So Chris, talk to us about the project that you did with Jordan Wang. And I agree with Matt. You know, I think the states vary. In Colorado, where I live, there was something called Rule 800. And like an 800 call, it's basically a free pass. It said that the supervising physician needed to be within 30 minutes of the facility. They didn't say by car, by taxi, or by F-18. They actually just said within 30 minutes of the facility. So Chris, talk about your project.
Well, briefly, I will tell you that this paper, it generated a lot of negative comments from our colleagues, our physician extenders, particularly from Canada, where they were very upset that in the medical spa areas where we found that there was probably at least double the amount of injuries as opposed to a medical private practice. Now, I want to tell you, first of all, that none of us here is without complications. Physicians can absolutely get complications. The more you do, you know, hopefully the better you get, but you will still have complications periodically. But having said that, if you're less well trained, and if you have no supervision, we really found there was a significant increase in complications. One of the major problems, though, you know, if you're a patient and you've got a physician who's been involved in the care, you know, you can develop a malpractice case. But in cases where the physicians are not involved, it's more difficult to get to sort of justice, should we say? But in any event, it was a useful article. But it did raise the ire of our paramedical group.
Fantastic. Thank you all very much. This has been an incredible episode of Scientifically Speaking.